Everyone, today I'm going to explain what is the hemophilia. So there are the two words philia and phobia. Philia means love and the phobia means fear. So hemophilia is the love of blood, that is the love of bleeding. That's why the name is derived. The hemophilic person is said to be love of bleeding because the typical clinical presentation of hemophilic person is bleeding from more than one place, either oral, nasal, intramuscular, intra-articular, bleeding from large joints. That is the typical clinical presentation even after minor injury. So the main pathology behind the hemophilia is two types, type A hemophilia and type B hemophilia. So there is a deficiency of coagulation factor in our body. So blood is not stopped after injury. So after injury, even after the minor trauma, there is a formation of hematoma in hemophilic person. So by the definition, there is a deficiency of coagulation factors. So what is the coagulation factors? What is the mechanism to stop the bleeding in our body? There are the two mechanisms which we generally known as a hemostatic mechanism. So that is the two main mechanism is primary hemostasis and secondary hemostasis. Primary hemostasis, in which there is a main function of the platelet. As soon as there is an injury in our body, there is a blood oozes out from the leaking vessels. So platelets, with the help of one Willebrand factor, attach to the leaking site and form a platelet plug on that side. So that is the primary mechanism. But primary mechanism is very unstable. Our body required very stable mechanism, more stable mechanism. So more stable is the coagulation mechanism, that is the stopping of bleeding with the help of coagulation factor. So our body containing two types of coagulation factor. One is the intrinsic coagulation factor, which is already present on the blood, and second is the extrinsic coagulation factor, which is present on the tissue. So as soon as the injury occurred, the coagulation factor activated themselves and form a fibrin plug, fibrin deposition on the site of leaking vessels. So the main function of coagulation factor is to convert the fibrinogen into the fibrin, and that fibrin deposit into the leaking vessels. So there are the two types of hemophilia, type A and type B. There are the 13 coagulation factor, number 1 to number 13. So in hemophilia there is a deficiency of factor 8, and hemophilia B there is a deficiency of factor 9. These are both factor 8 and factor B comes into the intrinsic factors. Okay, so what is the importance of X-linked recessive disorder? This is the hemophilia is the X-linked recessive disorder. We all know that female containing 2 X chromosome and male containing 1 X and 1 Y chromosome. Suppose this X chromosome containing gene for hemophilia and another X chromosome containing complementary copy of that gene. So in the female, if one gene is not working properly, complementary copy is still working. That's why the female is never affected in X-linked recessive disorder. Female is always carriers of the disease, because female containing genetical mutation but does not presented with the clinical features, while in the case of male it's containing only one copy of X chromosome. So male is always affected in the X-linked recessive disorder, especially maternal side male patient, and the female is always carrier in this disease. So mode of inheritance is X-linked recessive disorder, and typically positive family history, especially on the maternal side of male, like maternal grandfather, maternal uncle, maternal male cousins, because the females are carrier. So if you want to complete history, we should search for the genetical mutation in maternal male, like maternal grandfather, maternal uncle, and maternal male cousin. So this is the typical chart of what happened when a carrier woman married to a normal man. So 50% daughter become carrier and 50% son become hemophilic, while the 50% son is normal and 50% daughter is normal. So there is a 50% chances that the daughter and the son affected from the hemophilia, and there is a 50% chances this son and daughter become normal. So that is the importance of detection of carrier in the hemophilia. Queen Victoria was also hemophilic carriers. So that is the this one is the chart of primary hemostasis. This is the vascular wall of the vessels. With the help of one Willebrand factor present in the endothelial lining. So von Willebrand factor with the help of glycoprotein 1b attached to the platelets. As soon as the platelet attached to the glycoprotein, it secretes glycoprotein 2b and 3a, and that attached to the another platelet. In this way, there is a formation of platelets plug on the leakage sites. So but this mechanism is very unstable. It's need a stable mechanism. What is the stable mechanism? That is a coagulation factor. So there are the two types of pathway: extrinsic pathway and intrinsic pathway. Extrinsic pathway started from the tissue injury and which activated factor 7. Factor 7 activated, and the intrinsic pathway which activated by the surface contact, it's containing 12, 11, 9 and 8, and finally both pathway converge on the factor 10 and ultimately result in the activation factor 10 activation. This A is represented activated form. So the common pathway, that is the factor 7 and factor 8, convert factor 10 into activated form. That factor 10 converts prothrombin into thrombin, and that thrombin converts fibrinogen into the fibrin. Initially there is a formation of monomer, two or many monomers joined together to form the polymer, and with the help of factor 13, that is clot stabilizing factor, there is a formation of fibrin clot on the leakage site. So this is a very stable mechanism, and in this way there is a formation of clot and ultimately result in stop of the bleeding. So in the hemophilia, both factor number 8 and factor 9 are absent in the patient blood. So there is a no activation of intrinsic factor, there is a no formation of factor 10, there is a no formation of fibrin from fibrinogen. So that is the main pathology in hemophilia. So the typical presentation of hemophilia depend upon the severity of factor 8. It is divided into 3 categories: mild, moderate and severe. Severe patient presented with the spontaneous bleeding even after minor injury, and the mild type presented bleeding after major trauma or major surgery only. So in the mild form there is a more than 5% of factor 8 activity. In the severe form there is a less than 1% activity of factor 8. So bleeds in hemophilia, where the bleeding occur in hemophilia patients from the oral cavity, intra-articular. Most common joint involved is the knee joint, then genito-intestinal, gastrointestinal and genito-urinary. Bleeding from the urine, bleeding from the stool is the typical presentation. Sometimes intramuscular bleeding, and in some patient there is a intracranial bleeding also there. Intracranial bleeding. So intracranial bleeding is the most common cause of death in hemophilic patient. So target joint is the typical presentation of hemophilic patient. What is the target joint? There is a immobile joint where there is a frequent bleeding and the frequent healing in one particular large joint, and their vicious cycle is continuing and ultimately resulting in the destruction of the cartilage, formation of some cyst, osteoporosis, and ultimately result is immobile and disorganized joint. There is a intramuscular bleeding, intramuscular hematoma in some patient, and intracranial bleeding can also occur, or intracranial bleeding is the most common cause of death is in hemophilic patients. So this is a typical picture of intramuscular bleed. There is a formation of localized hematoma which resemble like a tumor, that's why it is called as a pseudo tumor, and that is the intra-articular bleed. Intra-articular bleed, there is a diffuse swelling on the knee joint. So this is a typical presentation, patechi in the case of platelet disorder, and that is a swelling, that is the hematoma in the case of coagulation disorder. So there is a difference between the primary hemostasis and secondary hemostasis clinical picture. So this is a radiological picture. There is a decrease in intra-articular space and ultimately result in immobile joints. Now come to the lab diagnosis. Now when we how to approach the bleeding disorder, when to suspect the bleeding disorder, that is the most important thing. That is the repeated episodes of bleeding from more than one side, maybe from intramuscular, intracranial, from genitourinary, gastrointestinal. Then bleeding disproportionate to degree of trauma, that is the more important, because the hemophilic patient bleed more as compared to degree of trauma. Even on the minor trauma there is a diffuse hematoma formation. Then next step is to confirm the nature of disease, whether it is hereditary acquired, whether it is due to primary hemostasis mechanism defect or secondary hemostasis, that is a coagulation defect. Now come to the next, that is the third steps, that is a confirmatory, that is the screening test, and fourth is the confirmatory test, and final is the diagnosis. Now come to the screening test. The most common screening test is CBC, bleeding time, clotting time, PT and APTT. Now in the case of primary hemostasis, when there is a deficiency of platelet or platelet is not functioning well, so bleeding time is increased. But in the case of coagulation factor, clotting time is increased, PT is increased, and APTT is increased. Prothrombin time measure the extrinsic pathway activity, and the APTT, activated partial thromboplastin time, in measure intrinsic pathway activity. So in the case of hemophilia, there is a intrinsic pathway defect, so APTT is always prolonged, PTT is normal, clotting time is increased, platelet is normal, and bleeding time is absolutely normal. Now come to the specific test for bleeding disorders. So first is a platelet aggregation study if you suspect that is the platelet functional disorder. Now come to the coagulation factor deficiency. Coagulation factor assessment of factor 8 and factor 9 activity in the body is most important, because both are decrease in hemophilic patient. Then estimation of fibrin and fibrin degraded product like FDP and D dimer, these are all increase in coagulation profile. Now in the case of primary hemostasis, we should perform platelet count and bleeding time. There is a defect in platelet count and bleeding time. In the case of secondary hemostasis, PT or APTT is normal. So in hemophilia, APTT is always prolonged, while PT, prothrombin time, is always normal. So there is all other causes also to for increase APTT, like SLE. Then specific inhibitor of coagulation factor is present in the blood. So to rule out, we have to perform mixing study. So what is the purpose of mixing study? We mix the 1:1 ratio, that is the 1 ratio of patient serum, patient plasma, and one from normal person. So if after mixing, if the APTT is normal, there is definitely a deficiency of coagulation factor. Then go for individual assessment of factor 8, 9, 10 and 11 or 12. If it is not prolonged, if it is partially or not corrected after mixing with the normal plasma of the patient or with the normal plasma of the normal person, so there is definitely some inhibitors which is present in the blood, like SLE or lupus inhibitors or some factors. So go for antibodies screening for SLE or lupus anticoagulant. Now come to the treatment. Treatment is, so ultimately there is a deficiency of factor 8. So we have to provide either factor 8 concentration or cryoprecipitate which is rich in factor 8. Now some drugs are available like desmopressin, which increase the factor 8 and von Willebrand activity in the plasma. So the factor 8 present in the two form, plasma derived and recombinant. Recombinant is genetically prepared, is safer as compared to plasma derived, because the plasma derived factor containing risks for bloodborne infections. Thank you.